Wonderful. Okay, well, welcome to everyone for our Wednesdays at noon, our center research rounds. And this is our last one of the term. And I'm so excited that we have Ishani Khanna, who is a Bachelor of Science of Nursing student presenting on Canadian Frailty Network Summer Student Project. And we also have Ben DuPlessis, who's an MD student presenting on resettled refugees' experiences accessing and using mental health care services in Canada and preliminary findings from a scoping review. So thank you to both of you so much for presenting, and we'll split the time, and Ishani, you can present first and have some time for questions hopefully, and then we'll pass it over to you, Ben, for the second part. All right, so we'll turn it over to you, Ishani, and you're going to, I think, share a screen. You have your PowerPoints?
Yeah, I'll share my screen.
Great.
I haven't done this before, so hopefully it works fine.
Oh, and I see Ben has some audio, but you've got about 20 minutes to figure it out.
Okay. Oh, sorry. I think.
Yeah, that's all right.
Okay, it's saying that in order to share my screen, I have to quit Zoom. I'm not sure if that's gonna log. It might log me out.
Yeah. All right. So any suggestions, Judy, or if you want to go back out and back in again, feel free.
I also did share the PowerPoint with you, Julie, if you wanted to just share the screen, maybe. And I can just tell you when to.
Do you want to just go out and join again, and then you'll be.
Sure. Yeah, I can do that.
Yeah, that'd be good.
Perfect. It's working. Oh, there we go. It's great. It's all full screen. So we'll just turn it over to you. Oh, and you're on mute.
Okay, can you hear me now?
Yes.
Okay, sorry. Yeah, so my name is Ishani. I'm a semester 7 nursing student at Dalhousie University, and today I'm going to be presenting my summer project with the Canadian Frailty Network. So the Canadian Frailty Network is a non-for-profit network funded by the Federal Networks of Centers of Excellence program, and their mission is to improve the care of older adults living with frailty to support their family and friend caregivers. The Canadian Frailty Network Summer Student Award Program is an interdisciplinary program that's designed to provide participants with a frame of reference for examining healthcare experiences for Canada's older adults living with frailty. So I applied to do a project aligned with a research project exploring the care of people with dementia in hospital. And so before we begin, I'm going to start with a definition of frailty. So frailty refers to older people living with multiple chronic or ongoing health conditions that make them vulnerable to poor outcomes. And in Canada, there's a growing number of people diagnosed with dementia, which is a condition that's often associated with frailty. Improving the healthcare for people living with dementia is a national priority, and this is particularly true in acute care settings. So in order to improve the care of people with dementia, it's important to gain their perspective on their experiences in hospital and identify ways for the healthcare system to address their needs. So yeah, the overall title of the project is Nursing Interventions to Improve Care of People Living with Dementia in Hospital. And then sort of within this large scale project, my specific summer project focused on learning about the process, the research process, and the lived experiences of people with dementia. So the methods that I took to achieve this goal included completing an annotated bibliography, observing interviews with people who were living with dementia who were admitted to hospital, consulting with stakeholders of the Alzheimer's Society of Nova Scotia, and also engaging in participant recruitment. So just for some background information, the Alzheimer's Society of Nova Scotia offers many supports for people living with dementia, such as educational opportunities, programs, and services. Through consulting with the research liaison at the Alzheimer's Society of Nova Scotia, I learned about her different roles, including promoting research as a strategic priority for the organization. And she also coordinates outreach to healthcare providers as part of the direct referral program and provides education and supportive counseling to people living with dementia and their care partners. So I assisted sort of with the participant recruitment portion of the study by reaching out to different organizations with the recruitment poster that we had, and also posting it on social media platforms, so Twitter and Facebook. And we were also able to get it out in the Alzheimer's Society Nova Scotia newsletter. The slide focuses on how my methods that I just previously mentioned informed my learning throughout my experience in the summer. So I was able to learn that meaningful engagement requires a holistic approach that acknowledges the citizens' characteristics, demographics, and their social support network. So throughout the recruitment process, I learned that participating in research without much prior experience might be sort of frightening or intimidating. And it's important for the researcher to, and the research team, to just be mindful of attitudes that are sort of portrayed to the citizens. So this can include just sort of changing up language and making sure that there isn't too much research or medical jargon. And then through my activities with the Canadian Frailty Network, some of the educational activities that they provided, I was able to learn that in Canada, there's an estimated 4 million Canadians caring for older friends or family members. So it's an important aspect is ensuring that there's focus on engaging both older adults living with frailty and their family and friend caregivers. The annotated bibliography provided me with an opportunity to explore qualitative data on the experiences of people living with dementia and their caregivers in hospital and how certain contextual factors can influence the care that's provided. And then my interviews, I was able to gain first-person perspective on the experience of people living with dementia who were admitted to acute care hospitals, specifically in Nova Scotia. So although this project is still in progress, I was able to learn a lot this summer, and I spent some time reflecting on my experiences. So when considering the interviews that I had observed in conjunction with the qualitative research that I read through my annotated bibliography, I was able to reflect on certain themes that had emerged. So the first theme is lack of communication. The lack of communication between nurses can affect the experience of care for people living with dementia. So there appears to be a lack of communication during transfer of care. And essentially, people living with dementia in hospital may experience or have specific considerations regarding their care. And these considerations or issues would be addressed, and then they would either be resolved or they wouldn't be resolved by the nurse who is working that shift. But as we know, nurses oftentimes they do shift work, so the staff changes every 12 hours. So this could then result in the same situation sort of arising for the patient when a new staff member would take over care, and this could become frustrating just because it's a change of staff every 12 hours. So then that loss of communication could then create frustrations for patients. So I'm going to be talking a little bit about an interview that I had observed, and I'm going to be referring to the person we had interviewed as the respondent. So in the interview, the respondent shared a story about how the nurses needed blood work. The respondent expressed that they needed a certain needle, and this is called a butterfly needle. However, the nurses insisted that they didn't need to use this. The nurses poked the respondent a few times and it didn't work. The respondent then expressed again to the nurses that it would be much easier if they just used the butterfly needle. The respondent stated they wouldn't listen to me. I was getting so frustrated and mad. Finally, it worked with the butterfly needle. And then the next morning, the new nurse came to get blood work. So this is the nurse that would be taking over care after the 12-hour shift. And they didn't bring a butterfly needle. So the respondent explained that they had asked the nurse to put up a sign indicating they wanted this specific needle, but the respondent stated that it never happened. So it seems that patients might have a difficulty in successfully communicating their needs to nurses, and this can result in a lack of involvement in their own care. And based on current literature, and this is was found in an article that I had read through my annotated bibliography, nursing staff's lack of knowledge about a patient at the beginning of each shift exacerbates the experience of stress for patients living with dementia. The second theme that I was able to reflect on is the stigma associated with dementia and how it's enacted by healthcare providers. So in another interview, the respondent explained that they had hallucinations in the hospital, and this is related to their dementia. And the respondent stated, they just kind of look at you like you were crazy. So this statement had me reflect on a key finding in another study, which found that participants expressed strong negative opinions about their care, feeling devalued and disempowered due to discriminatory labeling and cultural attitudes towards patients living with dementia. So overall, this program was a very valuable experience for me, and I just sort of want to touch on main takeaways. So one of the main takeaways is sort of how I'll use what I learned about the nursing care of people living with frailty and dementia in hospital to inform my future nursing practice. A major implication is recognizing the importance of knowing your patient. So this can include ensuring to do a thorough report at shift changeover. It's also important to be aware of small details of patients and transfer information so that they aren't constantly repeating themselves. And it's also crucial to create an open space for your patients to communicate and not sort of making them feel like the knowledge that they have isn't valued. And then another key takeaway for me is acknowledging the stigma and stereotypes that can be associated with a dementia diagnosis. So as a healthcare worker, it's important to be aware of manifestations of diseases such as dementia and provide person-centered care, which includes understanding how patients might feel in certain situations and not further contributing to their stigma. So just with sort of the nature of nursing in an acute care hospital setting and from kind of what I've noticed through my own experience of being a nursing student on many acute care floors in the hospital, it is busy and fast paced. But I think regardless, something that I hope to kind of share today is just recognizing the value in taking time to listen to your patients and making whatever efforts you can to establish genuine connections. I sort of reflected, and I think a big thing for me is just, sometimes working in the hospital, you might not have all the time that you want to be able to sit with your patients and listen to everything, but just taking at least some time before every shift. So whether that's day shift or night shift, and just going to your patients and asking them, is there anything that, I can take into consideration before the shift starts that, might make it go by a little bit easier for you. So yeah, I think that was like a big takeaway, is just establishing those connections. And I would just like to thank the Canadian Frailty Network for providing me with this opportunity, and also to Dr. Elaine Moody, who's been a very supportive supervisor and mentor throughout my summer project and as a research assistant and student. So yeah, leave the floor open to any questions or comments. And sorry, my references are there as well.
Great. Thank you, Ishani. A couple of people had to leave because there was a fire alarm in the nursing building. So, but hopefully they'll be able to come back. We do still have people on board. So, oh, Elaine's clapping. So if you want to look at the chat bar, and I offer to our audience, please, if you're there, ask some questions, comments. That's fantastic. I just want to let you know, Ishani, I wasn't able to see your slides changing.
Oh,
I heard what you said beautifully and love your research.
Oh, you can see the slides.
Really, really proud, but we couldn't see the slides. Anyway,
oh,
just
oh my
FYI.
gosh. I'm so
Something
sorry.
just didn't work. No, don't worry.
I wasn't seeing the comments come through as I was presenting.
Yeah, and I didn't want to interrupt you, but we could hear you beautifully. So
I can send the presentation out, maybe like the PowerPoint or something to.
Okay, yeah, and if anybody would like, anyways, if you would like to share them, let us know, and then people who hear, they can always ask. So I see, Elaine, you're on board there. Would you like to say something?
Yeah, great job, Ishani. Really nice to hear your reflections on the project and how you'll be taking what you learned in the summer to your nursing practice. So that was just really inspiring to hear, and it was really great working with you over the summer. So wondering if you could talk or say anything about your experience being involved in research. What was that like for you?
Yeah, so research is something that I feel like I kind of learned, just sort of going through the nursing program and learning about how there's so much more to the nursing practice, like how relevant keeping up with research and everything is. I kind of wanted to become involved with it. And then I think it's just especially the sort of qualitative aspect of the research process and everything, I kind of was able to just learn the value of that and kind of like how important it is to create meaningful relationships with the citizens who you're going to be engaging with, and things like knowledge translation and that kind of thing. So yeah, I'm really like thankful and fortunate for the opportunity to be able to be involved with research as like in my undergrad, because it kind of like opened up my perspective as to like what I can do in the future and continuing research on as a nurse and everything. So even like if I continue working as a nurse and I don't just pursue research, it's the idea of like keeping up to date with best practices and what's out there and all of that. So yeah, I think it's really valuable to be able to have that opportunity, especially as an undergrad student working, in the healthcare field.
Great, thank you.
Yeah, comments, questions from anybody else? If you're still there.
Yeah,
I know some people might just had to step out. You usually have to go into the courtyard and then they can come back into their offices afterwards. Yeah, no, being a qualitative researcher, this is so exciting. And I know how much work qualitative research is. So very impressed. The quotes from the participants, I mean, they just tell so much. And I love the way that you presented the really, unique ones that stood out and represented, I guess, comments from many participants. Yeah, and just the messages that you gave to other healthcare professionals, like what needs to be done based on patient experience. So it is the patient voice and bringing that in, and it's just so powerful. So I don't know, just want to comment on, the patient voice.
Yeah, I think it's just really valuable to be able to have that first person perspective, because at the end of the day, like no one really knows what someone's going through, and like besides the person who's going through it. So just to be able to sort of listen to what the patients and whoever's experiencing it has to say is really valuable. And I think that that's something that healthcare workers really need to take into consideration, and empowering their patients and sort of making sure that the knowledge that they hold is being respected and it's not kind of just out the door. I think that will help to kind of create those genuine connections that I was kind of talking about at the end of my reflection piece. Yeah.
Right. And did you do the interviews?
I just observed because
Yeah.
I've never conducted an interview or anything like that. So I just was able to have the opportunity to kind of listen in and hear what they had to say.
Yeah, no, yeah, and just being there, because I often say healthcare professionals, because of your interviewing skills and listening, make great researchers. So there's kind of a similarity there, I often find.
Yeah, no, I think it was a really good opportunity, like especially just being like an upcoming nurse and everything, being able to hear something from the patient's perspective like that was really valuable. Yeah, and I'm definitely going to be able to take that into practice for sure.
Mhm. Yeah, no, definitely. Yeah, so research, you can put it into practice. So I love that, bridging it. Other people, I need to stop talking. Go ahead. Any other questions or comments?
I keep talking too, but I can ask another question. One of the things that we found that really came up was about stigma related to dementia specifically. Particularly when participant talking about really being fearful of talking about their symptoms that, like hallucinations, and how they might be perceived by the healthcare providers, but also how that's kind of internalized. But wondering if you learned anything, or if you have any thoughts on stigma in the healthcare organization and how it's, I guess, perpetuated and reinforced, or anything like that. Is there anything you came across in your annotated bibliography, or your other experiences?
Yeah, so I wouldn't say in the annotated bibliography, I feel like it was like I'd be able to speak on this more from just like past experiences, because I didn't come across too much of that kind of like literature through the bibliography. But I just feel like just like going through nursing school and learning like kind of about the importance of self-reflection and like reflecting on your own biases and stigma that you have, like not even just surrounding older adults, but like mental health in general, and different diagnoses and stuff. Like I think a big one that I remember learning about in one of my courses about people who are living with dementia is like sometimes like healthcare providers might, if someone comes in with a caregiver, they might direct their whole conversation or questions or everything towards the caregiver, and like that's kind of how it can be enacted by healthcare providers too. And it's, so you need to like acknowledge, I feel like, reflecting on why are you acting the way that you're acting, and that kind of thing, and just taking like the time to actually reflect and educate yourself. And that's something that like I want to make sure that I do too, because as much as everyone hopes that they don't have these like stigma and biases, I think they're always there. And like if you're not consciously like making an effort to think about them and reflect on them and question them, then it's going to show up in your practice. So I think that kind of goes for all aspects of like healthcare and diagnose, like different diagnoses and mental health conditions and everything like that. So yeah.
Great. And we just have a few more minutes if anyone else had a comment or question.
I just had a quick question. Can you hear me? I haven't tested my mic out.
I can.
Yes.
Great. Yeah. So I was just wondering if you had, and maybe you said this and I missed it, but like a sense of symptom severity of the patients who are being interviewed. Like, did they have like MMSE or MoCA scores or anything like that done?
Elaine, you might be able to touch more on this, because I know that you did the interview directly.
No, we didn't do an MMSE or a MoCA score. It was a self-reported diagnosis of dementia.
Okay.
And they both were early stage. So very high functioning, I guess you could say. So we did talk a little bit about their diagnosis, what their diagnosis was. And I understand you're in medicine, so you probably know this, but of course, the presentation of dementia is very different depending on what type of dementia you have. So Lewy body frontotemporal, you have Alzheimer's disease. So they both had kind of unique, less than typical presentations of dementia. So when you think about dementia, you often think about memory impairment.
Mhm.
And that's kind of often the first thing you see, but both of the people that Ishani was involved with had other types where memory loss wasn't the kind of primary presentation.
Okay. Yeah,
Mhm.
interesting. It just sounded like they must have had pretty good insight into, the development of dementia and how they were being perceived. So I was just wondering about that. Yeah,
Absolutely.
thank you.
Yeah. And just as an aside, because it's kind of my area of research, I think it's often the perception that people with dementia can't contribute to research, but finding ways, like even if it's not a verbal thing, you can, watch their behaviors, talk to caregivers, see how they respond throughout kind of, the progression of the condition. And with some types of dementia, people still have a wonderful memory.
Mhm.
So their presentation might be more decision making or like communication challenges, more kind of centrally than the memory impairment. But one of the participants actually took extensive notes about her experience in hospital, and she kept saying, "If I didn't have these notes, I wouldn't remember." But it was really, a great kind of compensating mechanism. Yeah, and it was
Mhm.
valuable to
Mhm.
us. Yeah.
Yeah, really interesting. Cool.
Mhm.
Great. Okay. Well, thank you so much, Ishani.
Thank you.
And thank you to everyone for your questions and comments. All right. So we're going to turn it over to you, Ben. Are you sharing us your screen?
Yes. Yeah, I
Okay.
should be able to. And yeah, I have like a bunch of stuff on my slides. So if they aren't showing up for some reason, I guess just like let me know. So
All
that I
right.
can
I
see
will
if I
type
can
things
see.
in the chat bar. To let you know.
Okay.
Great.
Or
No, so
even just
welcome.
yeah. Okay.
Yeah.
Let me see here. Okay. Is it showing up?
Yes, it is.
Okay,
Perfect.
and if I just test,
Yeah, see if it forwards or not.
does that work?
It does. Yes. I should
Okay,
have done that with
awesome.
Ishani. Sorry. Okay, over to
Yeah.
you. We'll let you take over.
Okay. Thank you, Ishani, for going first. Appreciate that. Really interesting stuff. My name's Ben DuPlessis. I'm a fourth year medical student at Dal. Here to present a study that I've been working on recently. It's a scoping review titled Access to Mental Health Services for Resettled Refugees in Canada. I was lucky enough to work with a couple of co-investigators on this. Emma Cameron, who did a lot of the screening with me, has been doing a lot of work on the manuscript that we're trying to submit, and just generally guided kind of the direction of the project, the things that we were looking at. And if you like the way that this PowerPoint looks, I didn't have a lot to do with the aesthetics. She did a lot of that, so thank you to her. We also worked with Melissa Rothfuss, who's a librarian scientist, and she helped us put together the search strategy that we used. Thank you to Melissa. And the project was supervised by Dr. Tim Holland, who's a family physician here in Halifax, and he's the medical director of the Newcomer Health Clinic. So he had a significant amount of research and helped guide us, our experience on access to healthcare for this exact population, which was great. So just a little bit of background on the area. When we started the project, we really wanted to focus on refugees who had resettled in Canada as a population. Now, it's kind of, they're often looked at as kind of a monolithic population of just refugees, but it's important to realize that they're coming from a huge variety of countries around the world with a huge variety of languages spoken, cultures that they're a part of. So we kind of need to keep that in mind throughout this whole thing. And we wanted to look at specifically what are the issues that they're having with accessing mental health services here in Canada, any barriers that they encountered, things that made it easier for them to access this. And just a kind of a definition here, the Convention relating to the status of refugees defines a refugee as someone who has fled their country of origin because of a well-founded fear of persecution as a result of their race, religion, sexuality, nationality, or political beliefs. And that's from the United Nations General Assembly in 1951. They came up with that definition. Important also to say that the process of gaining the designation of a refugee can take a long time, and it can be really tedious and confusing. There's a lot of bureaucracy behind it, but basically you have to have left your country of origin. So you can't be, it's not enough to be, to have fled, say, your home province and stay within the country. That would just make you an internally displaced person, which we didn't look at because they wouldn't have been in Canada. So once you've left your country of origin, to oftentimes people will wait in another country while they're waiting for the UN to give them specific status as a refugee, and then to match them up with a home country or a host country to be resettled in. And that can take years. I've heard lots of stories about people who, you know, maybe it's just a couple of years that they wait in a refugee camp, or maybe it's like, you know, I've encountered people who've waited 20 years or more, adults who were born and raised in refugee camps waiting to be resettled. And conditions in camps can be, you know, fairly hectic, fairly dangerous, low access to healthcare sometimes. And there's, again, a huge variation in this from country to country. But just something to consider. So this is a population who have fled their home country, often leaving behind family and friends, usually have a significant amount of trauma from that. And then if they've had to wait in a refugee camp, you know, this is a difficult place for people to live as well. So that can be especially traumatic for people. So kind of all these things are affecting this population before they even come to a resettlement country. And speaking of those countries, there's Canada and at least 28 other countries around the world. You know, the United States in the past has taken some countries, European countries, and some Asian countries as well. They play an important role in resettling and accepting a certain number of refugees per year. And Canada has kind of been at the forefront of this for some time. And this has been shown to be a life-saving strategy and helping to mitigate the current refugee crisis, which we're in. Speaking of this, we're in a huge global refugee crisis right now, have been for some time. In the past decade, those numbers of refugees has only gone up. We right now have 82.4 million people worldwide who have been displaced. And that includes people who are seeking asylum and who have not yet gotten designation as refugees, as well as people who are internally displaced in their countries of origin. And 20.7 million of those as of 2020, and these are UNHCR numbers, which is the agency that handles refugee designation and resettlement within the UN. 20.7 million of those displaced people are currently refugees. Canada is, like I said, a huge force in refugee resettlement. Since 2015, we have resettled over 163,000 refugees in Canada, and there's been kind of a push for more refugee resettlement in the last 10 years, I'd say, here. So as mentioned, there's a significant amount of factors which can affect mental health and general health status and well-being in this population before they get to Canada, for example. And they're often considered to be at risk of developing mental health disorders, higher risk compared to the general population. And there's a good amount of research done on that. Traumas include things like poverty, insecure access to food or water, loss of family members or friends, exposure to real or threatened violence. These are often people from war-torn countries. Some of these refugees may have experienced torture, conflict. 75% of Syrian refugees, which were surveyed recently, had experienced or witnessed a traumatic event. Many refugees have mental health disorders, including post-traumatic stress disorder, major depressive disorder, and general anxiety disorder. Anxiety is quite high in refugee populations. And these are all significantly higher than general populations in the countries that they're settled in, and in age-matched patients and people in their own countries of origin. And that's just before they get to a host country. Once they've arrived in a host country, there's another huge set of stressors which can affect these people, and often do. Things related to social determinants of health, so issues with employment, even people who were gainfully employed as professionals in their country of origin will often struggle with transfer of their qualifications to their new country. Plenty of issues with language. Language is a huge barrier for people trying to get work. On top of that, there are housing and food insecurities. People tend to get funding through the government for the first year of resettlement, depending on the method through which they're resettled here, and there are several. There's private refugee sponsorship, which private citizens in Canada will kind of raise money, and that's matched by the government, and they'll help settle people for a year. And then there's also people who are directly paid for by the government of Canada. But that only covers the first year, and beyond that, if they haven't been able to secure employment, then they're looking at housing and food insecurities. And even the first year, the amount of money that is set aside for these patients or these people often hasn't increased since the mid 80s, same as some of our other social programs. But it means that even during the time which they are funded, there are often a huge amount of financial stretches for these people. On top of that, you're dealing with lots of racism, xenophobia, people misattributing things to people coming from war-torn countries. This is very commonly reported in this population. And then the linguistic and cultural differences, which I've mentioned, that make it so hard to integrate. And these things can contribute to the worse mental health status that I previously mentioned. So when we're looking at access to mental health care in this population, we kind of hypothesized and saw in the literature a variety of potential things which could influence this. So among these were differences in how refugee populations in Canada kind of conceived of mental health and wellness, and we'll kind of get into the results and things that themes that emerged from the research, but just general different ideas which didn't match up with Western medicine on a variety of mental illness. Challenges of navigating the Canadian healthcare system. Anybody who's tried to navigate the Canadian healthcare system as a Canadian will know that it's not always straightforward. There's often a variety of barriers to access, whether that's just complicated sources of getting a referral to a specialist you need to see, or huge wait times, or not having access to a primary care provider, which is our next issue with access here. As people know, in Nova Scotia specifically and across the country, there's a shortage of primary care physicians and family doctors. There are some providers here and in other places in the country where the providers look specifically and treat populations, including immigrants and refugees, and that can be helpful, but many people are on a wait list for years to get a primary care provider. The cost of psychotherapy, going to a private psychologist, which is often the fastest option, for example, is $200+ an hour, which is if you don't have health insurance, I mean, it's a huge burden. A huge amount of stigma towards mental health among this population and among all populations, I think, but especially we were seeing in the literature review before we started, just it's those different conceptions that I talked about earlier, and different ideas about what it means to be healthy, about kind of the source of mental illness, whether it's a spiritual thing rather than, we would say, like a biological or physiological thing. And finally, lack of racialized and culturally / linguistically diverse providers. So a lot of people in the preliminary research who were kind of interviewed kind of talked about how it can be hard to open up to or relate to a provider who has no context for your life experience. So the objective of the study was to look at access in terms of facilitators and barriers to care for mental health services in Canada. We know that mental health service use among newcomers remains low right now. There's a good amount of research on this, but little is known about the experience of mental health access among resettled refugees in Canada. Not a ton of research on this specific question. So that prompted us to ask, okay, what evidence is currently available to describe access in terms of barriers and facilitators to formal mental health services for resettled refugees in Canada? And to best answer this question, we performed a scoping review. And to do this, we used the JBI methodology for scoping reviews, which meant that we needed to start by having some inclusion and exclusion criteria. So the population we wanted to look at was adult resettled refugees and refugee service providers. We thought that we could get a good understanding from both of these. And if there are differences between the adult and pediatric populations, so we decided to focus on adults for this study. The concept we wanted to examine was access to and use of mental health and wellness services. This was differentiated for us from perceptions of mental health, and there's some overlap there, which we'll get to, especially relating to stigma, but access was the primary concept that we wanted to evaluate. And the context for the study was in Canada. So a lot of research in this area has been done in Europe, a good amount in the States, and we wanted to specifically look at Canada, which is a little bit underrepresented, we were finding. So to come up with the search strategy, as I mentioned, we had a librarian scientist help us named Melissa Rothfuss. So she came up with a search strategy in consultation with us. And then that search strategy underwent a press. So another librarian scientist reviewed this search strategy to show that it was appropriate and comprehensive considering our study objective. And then we took this search strategy and we applied it to 5 databases, Embase, PsycInfo, CINAHL, Medline, and Ovid. We had found in our preliminary review of the literature that these databases frequently included relevant results, especially from journals focusing on refugee resettlements, mental health, and psychiatry, as well as looking at service providers from a variety of backgrounds, including nursing, settlement workers, psychiatrists, social workers, counselors, psychologists. So once we had the results, extraction and analysis, in order to do this, we developed a extraction tool, which was kind of a template that we used to pull specific data from the articles we were getting. And we trialed this on 3 articles, found that it was appropriate, made a couple of changes. And the goal in pulling this data from the resulting studies was to perform a kind of get a narrative analysis. So we really wanted to have an idea, not just of the numbers of things that were reported, but also kind of the specific stories and ideas that were being talked about by these studies. And then we also put together a table on barriers and facilitators, looking study by study and saying, okay, these were the things that they noted to be barriers or facilitators to accessing care. And that brings us to the results. So here's our Prisma diagram. We started out based on our search strategy, with those databases with 1,822 studies. 583 of those we dumped because they were duplicates. And of the remaining 1,239, 1,169 of those were irrelevant and screened to be kind of not exactly what we were looking for, which left us with 64 full text studies. We then screened those, and the primary reason for exclusion was that they were the wrong study design. So they were just, they were either an abstract and not a completed text, or maybe they were just talking about prevalence data for mental illness, which is not exactly what we were looking for, or a little bit off. And we used a hierarchical system of exclusion. So frequently those wrong study designs, of which there were 26, were also the wrong setting or not in Canada. So, they would have not met criteria for a couple of reasons. And that left us finally with 23 studies that we evaluated, which met our criteria. So some of the characteristics that we took from those studies or location, they could be, province by province, or sometimes we would note specific cities where things took place. We noted the method which was used, quantitative, qualitative, mixed methods, and then we had some further notes on the exact methods that they used. And then we noted various participant demographics, which, their LGBTQ status that came up several times, country of origin, if noted, whether or not they were a service provider, their age, the time that they had lived in Canada, things like this. And from this, we identified a couple of themes. So these are the big results that we found. So first one was the impact of social determinants on health. So this was pretty huge and noted in most of the studies that we looked at. The huge cost of medications, the cost of booking childcare and taking time off work if they had work, and transport to and from appointments, a massive barrier to people. And as mentioned, these are it's a population which tends to be very low income because of the variety of barriers that they face to employment. And they often had to focus on things that they deemed essential, like housing, attending work, things like this, long hours. And it was noted to be a huge barrier to people. Interestingly, some studies noted that virtual care was very useful for these patients, because it meant that they didn't have to take time away from their kids. They didn't have to look into transport. So that was useful for some. For others, there is, barrier to the linguistic barriers made using a Zoom difficult. To use a virtual care tool, you need to have something like a computer, internet access. Most everybody had a phone, and that was kind of easier. But for a lot of mental health services, it's really helpful if you can't see someone face to face, then to at least see them. To be able to read the kind of body language cues, which can be really useful, especially in somebody with language difficulties. Next theme we identified was the language barriers in education. So as I mentioned, these are people coming from a huge variety of backgrounds, languages, cultures, and it often made it difficult to match up provider with patient so that they spoke the same language, for instance. So it necessitated the use of translators or interpreters at times, which comes with its own challenges. So, having access to interpreters isn't always great access. Oftentimes, families would use their kids who had grown up in Canada and spoke English better, but this, people noted that you run into issues there as well with confidentiality, family interpreters not exactly interpreting correctly or not translating, the nuance of what you want to say, which in, assessing somebody for mental illness is huge, to know exactly what they're trying to say and to, elicit the symptoms, and the way that people answer is so useful for diagnosing people. One study found that in examining the factors that impact and attitudes towards seeking professional help, subscription to the Western model of stress tends to have a positive association, while supernatural beliefs have an opposite effect. So there was a huge variety of understandings that were reported about mental illness. Many people had never even conceptualized of mental illness. Depending on the cultures people were coming from, they would potentially say that somebody who had mental illness was being, possessed or visited by some kind of a spirit. And the rates at which people, subscribe to our kind of Western traditional thinking about mental illness, it was positively correlated with them using services. On the education piece, like there was another study that only found that only 21% of patients were able to state their confirmed diagnosis and describe the symptoms that they had that met their DSM-4 criteria. And this specific study was looking at a specific clinic which did match providers based on ethnicity and culture and language to the patients. So even in that context, it was very difficult for a Western provider to fully explain to some of their patients exactly why they believed that they were mentally ill, or how to explain their diagnoses to them. So this other theme is Eurocentricity, lack of culturally appropriate care. So it kind of goes around with what we were just talking about, the difficulty of matching cultural and language relevant providers to patients. And then the specific treatments were noted by a lot of the refugees who were interviewed in these studies to not match with what they would think of as appropriate or to their culture. So this came from a lot of like misunderstandings about people's backgrounds, having different life experiences, and that affected the quality of care. The influence of family was noted in a lot of studies. So in some studies, family members who had a different idea of mental illness would encourage their family members who were being treated to not take psychotropic medications for fear that it would make them worse. As I mentioned, a lot of family members were present for interpretive services, which was useful sometimes and not at others. And it was noted that having really supportive family members was a huge facilitator for access to care. Stigma was probably the single biggest theme identified through these studies. So using the word crazy to talk about anyone with any kind of mental illness was very common, regardless of cultural background. And the idea that having mental illness meant that you would be socially outcast, this was a very common belief, and that often stopped people from wanting to talk to providers at all. Interestingly, having somatic symptoms, so if on top of having depressive symptoms, you also had headaches or myalgias or muscle cramps or whatever you could have, this was a really positive predictive factor for people seeking service, which probably points to underlying stigma, like the idea that I would only go to see a doctor if I have something physically wrong with me, as opposed to a mental illness or something like that. So interesting kind of implication for providers that refugees coming in talking about somatic symptoms, that could be kind of an alternate form of help seeking when it comes to mental illness. Trusting providers and building good rapport. This was a huge theme and a huge facilitator for access. Patients in one study that attended a cross-cultural psychiatry outpatient clinic that matched up providers to patients in linguistic and cultural background. That ended up resulting in an increased likelihood of continuing positive treatment, and that was highly rated as a huge facilitator to care. A huge barrier being mistrust between patient and provider. So a lot of refugees interviewed in these studies noted that it had been adaptive for them in leaving their country of origin to be kind of secretive and mistrustful of people and hyper vigilant. in not wanting to, just very useful for fleeing a country, as it turns out, not as adaptive when it comes to getting treatment for mental illness. And then the final theme that we identified was the absolute importance of primary care. Most of the studies that we looked at commented on the huge importance of primary care as a means of accessing mental health services. So one study found that 83.2% of patients had listed family physicians as their primary pathway to mental health care. And another listed that all of their patients who had ended up getting mental health care did it by going through their family physician. So kind of points to discuss. I mean, I think the biggest takeaways that we found from this review were language barriers being a huge barrier to accessing mental health care. The kind of inappropriateness of some of Western providers and the way that they approach patients with matching up with refugees and their cultural background. The importance of involving family, not only in treatment, but in education. Because once they leave the appointment, the refugee or the patient will still exist within kind of their cultural context. So getting the family on board is a huge facilitator for treatment. And then just an absolutely massive kind of constant and study to study prevalence of mental health stigma and the importance of education around this. And this is not just an issue for refugees. I mean, anybody who's worked around mental health services knows that plenty of Canadians feel the same way. So the next steps for the project, we've talked about designing a clinical guidelines for the newcomer health clinic here, which tends to see refugee patients who've resettled in Halifax, just for accessing mental health services, education, like we talked about different mental illness. I'd like to maybe look into doing further research with more of a Nova Scotia specific focus, because we have a huge amount of refugees who've been resettled right here. And this manuscript from the study, we plan to submit that to the Canadian Journal of Psychiatry for publication as well. So in conclusion, there's a lot of work to be done in increasing equity. But luckily, this big population of refugees, they kind of come with an innate resilience because of the things that they've been through, all the things they had to do to get to Canada in the first place. And they're often very future oriented because of that. And that's all I have.
Fantastic. Thank you, Ben. What an amazing scoping review, and obviously a super important topic. It's 1 o'clock, but if people would like to stay for a few more minutes, then I'd like to open it up for questions or comments. And just a quick clarification, were all the studies that you found in Canada or they were global?
They were in Canada. So that was one of the specific exclusion criteria for us, was if they didn't take place in Canada.
Thanks for clarifying. I didn't hear that.
Yeah. Yeah.
It's okay. And yeah, I think we still have a few people.
I can ask a question. Yeah. Thank you for your presentation. That was really interesting, and everything is, super relevant. And I remember you mentioned like just kind of the aspect of mistrust being kind of a big issue, and not always being able to, I think you mentioned something like matching like refugees with providers who might have similar backgrounds. So I'm just kind of out of curiosity and your experience as a medical student, is there anything kind of that you've either learned like throughout your own practice, or even just like through the literature, that might help kind of like mitigate the issues that would come from those interactions, or even that might help like establish a little bit more of a trusting relationship? I mean, it's probably so complex, but I'm just wondering if you have any insight.
Yeah, I mean, beyond like having more providers from diverse backgrounds, which is like, takes a long time to do, and we we don't have as many as we definitely should, and we have, you know, all sorts of populations that are already underserved. I think there's like the stuff that you can do with any patient population. So spending a lot of time trying to build rapport. It's really hard when you're using an interpreter to do, just because, you know, you have to kind of wait, and some of the like the body language stuff that you can do to make people feel comfortable might not come across. And but I think just kind of trying to really help patients and remind them that you're kind of there to help them, and being really empathetic and listening carefully is probably the best thing you can do. And a lot of that is kind of cross-cultural, I would say. Probably the best thing to do, though, would be just to work on recruiting people from more diverse backgrounds to be service providers, I'd say.
Yeah, I agree. Yeah, thank you for that. And because it's definitely relevant to, you know, all healthcare practices like nursing too. So yeah, that's some good insight. And I did think a lot of it does come down to actually having healthcare workers and healthcare providers who do come from more diverse backgrounds, like you said. So yeah, that's great.
Great. I think we have time for one more question or comment.
I have a question, if I may. Very interesting presentation, Ben. I have a question. Actually, when we were talking about this search strategy, you said you underwent a press. Can you elaborate what press is? And my second question, I'm sorry I missed the first part because we were out because of the fire alarm. And so I'm just looking at statistics. So statistics-wise, is the mental health prevalence among the refugees comparable to the Canadian? How do we compare these numbers?
Yeah, so first of all, the press is just a peer review of the search strategy. So we had Melissa, the librarian scientist, who helped come up with our search strategy, took it to another librarian scientist and had her evaluated, just for, you know, completeness, were there search terms we were missing on that were obvious or should be included, just kind of to make sure that it was appropriate. And then the second question, I think there are 2 citations I had in the presentation, but we do know that there is a higher prevalence of a variety of mental illnesses among refugee populations. So among those, generalized anxiety disorder, major depressive disorder, various psychotic illnesses, all these things that have, you know, trauma and things like this as major risk factors, they tend to be higher. I don't have those exact prevalence numbers to hand. I think they may have been in the presentation, but I could always send them to you if you like. But there has been studies done on prevalence. It wasn't the main issue that we looked at in the study. Otherwise, I'd have better numbers for you. But yeah, they have been between, you know, immigrants of various backgrounds compared to people of refugee status, higher prevalence for a lot of mental illness.
Well, that's interesting considering if I compare where I came from and when I came here, I was kind of surprised by the mental health emphasis here, which we're not exposed to this much emphasis. And in my perception is that mental health prevalence is higher in this part of the world. And that's actually what we're told when we come from the other part of the world. So that's interesting. Thank you.
Yeah, it's interesting. And I wonder if it's, there's like a part of that is increased screening in North America or Europe. I'm not sure.
Well, we justify that by stronger family relationships and support system, religion. That's how the perspective we come from. So anyways, it's
right. Yeah.
Thank you so much.
Yeah, thank you.
Great. So I just want to say thank you so much to you, Ben. A wonderful presentation. And Ishani, also thank you to you. Sounds like there's probably all sorts of other questions and comments that people would like to make. Julie, I think, do we need to end or can people stay on if they want to chat?
They can stay on if they want to chat.
Okay, great. So if you want to stay on and chat, we can do that. I have to leave for another meeting, but thank you so much to everyone.
Yeah.
Thanks so much.
I'm just going to stop the recording because I too have to go. So